Good evening, everyone. I am Janet Griffin, and I'm the Director of Alumni Relations. On behalf of the Myers Alumni Association, I would like to welcome you all to this evening's webinar entitled A Disaster Nursing Retrospective. So I'm so glad that you've joined us here tonight. Again, everybody here at NYU Myers hopes that you've been safe and healthy during this very challenging time for us all through this pandemic, and we are glad that you've chosen during this very uncertain time to choose your evening with us. Normally, we have lots of events online that are hosted by the Alumni Association, usually like 15 to 20 events a year, but we've now turned everything into virtual events. So we are excited to be able to have alumni from all around the world, literally, that have joined us this spring for programming. So again, thanks for joining us again tonight. Our speaker today is Professor Theresa Bucco, and she is an assistant clinical professor at NYU Roy Myers, and her research interests include caring, patient satisfaction, and emergency nursing. If you have a question during the presentation, please type it into the Q&A box on your screen, and at the end of her presentation, we will get to as many questions as possible. So I'm going to go ahead and turn it over to Theresa.
Thank you so much. Thank you for asking me to do this. So this is a disaster nursing retrospective. Janet, the next slide, please. So we have some objectives, discuss the history of disaster nursing. We're going to review the historical disasters and response and examine some of the lessons learned in history. Next slide. So what is a disaster? We know that disasters have been part of the human experience since the beginning of time. They cause premature death, impaired quality of life, dislocation, and altered health status. They can be man-made or natural. Disasters actually reveal our vulnerability, unpreparedness, and struggle to mitigate the impact of these disasters. So in 1988, the Robert T. Stafford Disaster Relief and Emergency Assistance Act was passed by Congress and most recently amended in 2016. It provides for federal government assistance to state and local governments to help them in their management of disasters. So we use the definition of a disaster as stated in the Stafford Act. So a major disaster is any natural catastrophe, regardless of cause, in any part of the United States, which in the determination of the president causes damage of sufficient magnitude to warrant major disaster assistance, to supplement the efforts and available resources to states and local governments. So why is this definition so important? Because FEMA doesn't respond to the area until the president declares a disaster, and the local agencies need help. It doesn't have to be anything huge, large scale, but it just has to be something that is so overwhelming to the immediate local agency. Next slide. So what is disaster nursing? Well, generally, we know that nurses practice under conditions that are really plentiful. We have, great resources, and our situations are controlled. However, in a disaster, it can be quite the opposite. Caring for patients and the opportunity to save lives are what professional nursing is all about. Disaster events provide nurses with an opportunity to do both, but not always in optimal conditions. As nurses, we know we're optimally, uniquely qualified to manage emergency situations. We have knowledge of epidemiology, physiology, pharmacology, and cultural familial situations and psychosocial issues. Before disasters even occur, we want to minimize the effects if possible. It is important that we screen and identify the needs of vulnerable populations, such as the children, disabled, and elderly persons. Nurses can also advocate for significant leadership roles in leading health agencies and governmental bodies. We can engage in evidence-based policy making. A nurse can actually function as a first responder, a triage officer, a care provider, and providing education and emotional support. What is important to understand is that when the disaster is over, the nursing process doesn't end. Nurses are actively involved in helping those adjust and get comfortable with whatever is going to be their new normal. And you know, this is something that we have heard consistently throughout COVID-19. Slide 5, the next slide, please. So we say it's not a matter of if, but a matter of when. So this is something that I learned when I went down to the Center for Disaster Preparedness in Anniston, Alabama. But now it has taken on all new meaning. When is actually now. So we know that we are the largest portion of the healthcare workforce. We know that disasters are largely unpredictable, and it's possible that anywhere we work, we will be called on to assist with a disaster response. Despite suboptimal conditions that we may face in a disaster, we are still expected to minimize morbidity, mortality to the best of our nursing capability. Next slide, Janet. This is really interesting, the history of disaster nursing. So in the United States, the Civil War is cited regularly for the role of volunteer nurses. And for the stimulus, it gave Clara Barton to organize the American Red Cross, which she eventually accomplished in 1881. She said, "I may be compelled to face danger, but never fear it. And while our soldiers can stand and fight, I can stand, feed them, and nurse them." Most of the women were collecting bandages during the Civil War. She decided to assist soldiers in the battlefield. Next slide. So nurses have been a part of disaster preparedness as long as we've existed. Although the early nurses that responded to emergencies have been something other than the fully educated, licensed, certified professional nurses as we know them today, their role was still consistent with modern nursing. Understanding, attention to the injured, the ill, assuring provision of water, food, clean dressings, and bedding, providing relief from pain. And the final thing was offering that human touch that says, "I care." In Crimea, 18,000 patients were in hospitals with no nurses available. So Florence Nightingale actually gathered 36 nurses to assist in the Crimea. The hospital was in horrible condition. It was on top of a cesspool, and soldiers were laying in their own feces. Soldiers were dying from cholera and typhoid. But the most significant contribution of Florence Nightingale was to decrease the morbidity and mortality of the soldiers through the application of basic statistical analysis, infection control measures, and what we would now consider quality improvement measures. By World War II, formally organized nursing service had become part of the military, and the Cadet Nurse Corps was organized to quickly speed professional nurses through nursing school and into service. World War II influenced military nurses to acquire specialized skills, administering penicillin, doing triage and trauma care. Military nursing has helped the development of the advanced civilian emergency care like MASH units and trauma care. Next slide. So we're now going to move into our historical disasters, and we're going to start with the next slide, which is called the Great Fever, Yellow Fever of 1878. Yellow fever is thought to have originated in West Africa and been transported to the Americas by European trade ships. Historians think that it was around since actually 1648. One of the first documented outbreaks of yellow fever was by the Spanish on the Yucatan Peninsula in 1648. Now, this actually originated down south, and we need to think about the Mississippi River. The Mississippi River brought life and death to local inhabitants. Cities and towns lining the banks of the river were connected to an international trade network that actually offered great economic possibilities. However, the virus would also be transported via the ship to port cities of the United States. If this unintentional imported virus came in contact with a locale containing a susceptible population and a population of the mosquitoes, which were the disease vector, the right timing, the yellow fever epidemic was possible. So we see, I think this is the next slide, Janet. The Benjamin Franklin was a poorly constructed trading vessel which arrived at the port in Virginia in September of 1878. The port's health inspector actually learned that 2 sailors had died during their voyage from the West Indies. He quarantined the ship. Quarantining the ship in Norfolk, Norfolk was aspiring to be the queen of the Chesapeake and the rival of larger cities like Philadelphia, New York, and Boston, feared tremendous outbreaks of epidemic disease for their human impact and their negative influence on trade. And we know that's actually happening. The movement of people and goods along this network was not easily halted, so likewise neither was the spread of the disease. Next slide. So 2 groups are largely associated with the outbreak and spread of the disease. The crew of the Benjamin Franklin, the northern vessel sailing from the West Indian port, and the Irish immigrants of Portsmouth. The ship may have been the cause of the epidemic, but the Irish tenement dwellers were the victims of the disease. Norfolk's treatment of the Irish immigrants may explain the hostility and bigotry towards immigrants, which was common in this period. The Irish were targeted for their Catholicism, intemperance, and their failure to assimilate into American culture. Anti-Irish and anti-Chinese sentiment was well established at this point in history. And you can see this picture. Because most came from the United States penniless and struggling, they were also associated with poverty, crime, and disease. Irish communities were overcrowded tenements and were believed to have resulted in the spread of yellow fever. Next slide. So the Spanish actually called this disease vomito negro after one of its more gruesome symptoms. The name yellow fever was also derived from a symptom of the disease, jaundice, which causes the infected person's sclera and their skin to take on a yellowish hue. The vomito negro is the vomiting that patients experience is black vomit. The hematemesis is the most indicative sign of yellow fever. Additional symptoms of the disease included muscle aches, high fever, suppression of urine, bleeding from the nose, mouth, and gums. The yellow fever of 1878 in the United States was determined to be particularly virulent, violent, and actually quite fatal. It was understood that one attack usually gave immunity from a second, although this did not guarantee protection from the more malignant version of yellow fever in 1878. Next slide. So there were actually quarantine stations set up to protect the states, but they failed primarily due to non-disclosure by the crew members on the ships. They didn't disclose that they had yellow fever symptoms to the station physicians, nor were the physicians actually able to diagnose pre-symptomatic cases. So the pressing issue at the time was whether to quarantine or not quarantine the city. And you know that has been actually, something that we debated here in COVID-19. And nearly half the physicians in Memphis believed that the quarantine was not the right decision. 32 Memphis physicians were successful in petitioning the council not to impose quarantine. And the reason for this was they knew that the state was heavily in debt, and they believed that the proposed quarantine was going to be either unnecessary at the time or an exercise in futility. Also, they knew that it would impact the state financially. Once the word arrived in the surrounding areas that the disease was rampant, many other cities passed ordinances to protect themselves. What actually happened, the people in Virginia were frustrated with the quarantine imposed on them. It didn't stop them from establishing a quarantine of their own around the city that they viewed as responsible for their troubles. So they actually erected around the poor section of mostly Irish immigrants. They erected a 20-foot wooden fence. Next slide. Governor John Stone declared, "For God's sake, send us some nurses and doctors." Although there were 3 nursing schools established in large cities, nurses trained with others who had very rudimentary skills. During the epidemic, private relief groups assumed the responsibility for caring people with yellow fever. The Sisters of Charity and the Sisters of Mercy were volunteer nurses who worked with the Howard Association doctors. The Howard Association, and that's that gentleman that you see on my slide, was a philanthropic group known for recruiting doctors and nurses. Individual attention and hygienic measures were standard for yellow fever patients. Most people who were treated by the Howards actually did survive. Next slide. Okay, so during the 1870s, so we see this yellow fever, mosquitoes. There were very warm summers, relatively mild winters, and high rain day totals. In the fall of 1877 through the summer of 1878, it happened to be particularly favorable for the presence of high numbers of the A. aegypti mosquitoes. And we also experienced most abundant rainfall in those months. In mid-October, though, the temperature started to cool, marking the beginning of the active Aedes aegypti population, thus the spread of yellow fever. The Board of Health encouraged the refugee population to move away from the city until multiple hard freezes end the threat of yellow fever. On October 29th, they actually declared the epidemic over. Many African Americans at that time believed that these plague flies actually infested the region and were responsible for devouring the disease and the infestation of the mosquitoes. No doubt many believed that prayers were the answer. The work of the religious leaders and the Howard Association actually saved lives, but it did not end the epidemic. In reality, what ended the epidemic was a much simpler event, which took place during the early morning of October 14th, frost. The cold weather and freezing temperatures killed off the remaining population of the mosquitoes, which, unbeknownst to the population at that time, had been the carriers. So just so you know, we saw 16,000 lives lost, and the estimated loss to the country was $100 million. Other estimates place the death toll as high as 20,000 people and the economic losses at about 200 million, nowhere what we're seeing today. The 1878 yellow fever epidemic stands as one of the very worst catastrophes in American history, its toll surpassing that of the Chicago fire, San Francisco earthquake, and the Johnston flood combined. Actually, Clara Moss, you must have heard about her, volunteered to be bitten by the mosquito. She was a nurse from New Jersey. She died, proving that the mosquito was the vector carrying the disease. All right, next slide. We're now moving on to the 1918 flu pandemic. So there was a telegraph, a Red Cross telegraph to Washington, D.C. Influenza situation here, serious. Could immediately place 200 nurses. Can you provide them? So the response was, he can send all the doctors you want, but not one nurse. This was actually very prevalent in military recruits, the civilian population. Hospitals were overrun by patients. Cots were in hallways. Next slide, Janet. So this is a little bit about the introduction, the background, and description of the 1918 flu. So again, it's a biological event caused by the influenza subtype H1N1 virus. Is it a zoonotic disease? Unfortunately, in the absence of influenza virus sequence data in the years, this question was never definitively answered. Okay. The clinical manifestations. Okay, so let's talk about what actually happened. So influenza cases were widely reported in Spain due to the fact that as a neutral country in World War I, Spain did not practice censorship. So they never really let anyone know that they were experiencing a major health problem. All the other countries who were involved in World War I did not want to let their soldiers know that people were dying from the flu, because that would have really decreased morale. And it questioned their military readiness. So it was speculated that the military camps, with their high population density, their close proximity to livestock, that's where it actually started. And it was actually in a specific camp there. So what happened? There was the first wave, the second wave, and we actually saw chills, fatigue, fever, much like what we see presently. The second wave was cyanosis and fluid in the lungs. And the third wave actually came much later. Its high mortality rate was dubbed the worst natural disaster in recorded history. Next slide, Janet. So there's no real consensus on where the virus actually originated from. But we do know that it was Boston, Massachusetts, the military recruits, and they were in Camp Devens. And that's where we believe that it had started. Geographical areas that had a high prevalence of malnutrition experienced higher mortality rates from H1N1. Actually, geographical areas with high malaria rates actually experience high mortality. Next slide, Janet. So what did we actually see with this? So there were mitigation strategies, much like what we are doing today. So there was a strict maritime quarantine that was imposed by American Samoa by the U.S. governor. So this quarantine prevented influenza from entering into the country, and no deaths from the 1918 influenza was ever recorded in American Samoa. However, Western Samoa did not have the same quarantine, and it is estimated that the influenza killed more than a quarter of the population at the time. So they did everything much like we were doing. Social quarantining, reduce the spread. We used masks, hand hygiene. Um, they imposed restrictions on social gatherings. Schools, theaters, churches, and dance halls were closed. Mass gatherings such as weddings, funerals were banned in order to prevent overcrowding. But as soon as the restrictions were relaxed, it was usually within 2 to 8 weeks of the implementation, efficient viral transmission recommenced. So we found that face masks, if not worn or properly fitted, were shown to have no effect on prevention. It was very difficult to actually find medication. Vaccines was not available since the etiology of the flu was not known at that time. The nursing shortage actually increased, and because they were actually fighting in the war. And so nursing care was shown to increase survival amongst the ill, although there were few nurses. Next slide. Okay, so the Spanish flu was a viral respiratory disease, much like we know today, spread via droplets from coughing and sneezing. We know that flu patients are able to infect other people one day before they are symptomatic. Symptoms develop approximately 2 days after the virus enters the body. Therefore, it's possible that the flu patients can transmit the disease before they are even symptomatic. Infected patients are able to transmit the disease for 5 to 7 days after developing symptoms. So the most contagious period was within the first 3 to 4 days. Children and the immunocompromised may be contagious for long periods of time. Next slide, Janet. We know that the mortality rates varied immensely based on location. Congested cities showed higher rates of mortality, and we see this even present with COVID-19, New York City being one of the epicenters, showing the highest rates of congestion and rates of COVID-19. Actually, cities that used coal in their electrical generators had significant highly mortality rates, and locations that actually use hydroelectricity produced less pollution as well as had less mortality cases. Next slide, Janet. So what was so unique to the 1918 most deadly event in human history? 500 million people were infected and about 1/3 of the world's population at the time. 50 million people died. But what was unique about this flu? It didn't affect the very young or the very old. It actually, the usual age was about 20 to 40 years of age. Many people were moving around during World War I, and that may have caused the pandemic to actually become more widespread and present in the areas. And populations that were displaced by the war may have become more susceptible to the virus as a result of increased stress from being dislocated and displaced. Next slide, Janet. All right, so we look at communication. And during this time, there was actually no internet, no TV, no radio. Although the New York Times and Wall Street Journal existed, neither one properly covered the national presence of the disease. There were popular weekly and monthly magazines, but they only provided minimal coverage of the outbreak. Americans were completely dependent on their local newspapers to learn what was happening. It contained the U.S. Public Health Service instructions on how to avoid the flu and what to do if you contracted it. But remember, we're saying that communication was publicly announced through the papers. However, there were only very few stories about it due to wartime censorship, because we didn't want our enemies to know that we had this fatal disease going on. No country wanted to announce to the world the vulnerability of the soldiers or even to its civilians. During the early summer of 1918, when American newspapers mentioned the flu outbreak at all, they focused mainly on how hard it was hitting the enemy, not themselves. When the flu hit Spain, that's when it got actual press coverage, which led people to believe that it was originated in Spain, and that's why it was called the Spanish flu. Massive public health education campaigns were conducted to persuade people to cover their coughs, sneezes, to stop spitting, and it was enforced with fines and arrests. So next slide, Janet. Okay, so we look at the roles of nurses before, during, and after the pandemic. So according to the American Red Cross, they tried to recruit nurses, but many of the nurses were needed for World War I. So it led to a huge shortage of nurses here in the United States. The American Red Cross then started calling all nurses with any training, including African American nurses. Nurses were more in demand than doctors. Why? Nurses offered supportive care. They fed, they bathed their patients, they kept them warm, gave them fluids, monitored their conditions, sat with them, comforted their families when they died. Nurses were sources of psychological and emotional support to patients and their families. Nurses understood the social and community environments, played a huge role in patients' lives and well-being. They were advocates for social change. They not only taught patients, but also taught entire communities basic hygienic practices, educating on the importance of covering your cough, and spitting into handkerchiefs, boiling soiled linens, and opening windows for fresh air. After the pandemic, the nursing profession gained huge respect and growth. The 1920s and 1930s saw an increase in the number of hospitals and improved patient care. They both relied heavily on nurses' abilities. The profession expanded its training abilities. Nursing education was removed from its base within hospital training programs and placed in institutions of higher education and programs centered in two-year community colleges. The profession actually abandons its objectionable system of racial and gender segregation, opening up equal educational, professional, and employment opportunities to all nurses. Next slide, Janet. And so with this, the Red Cross volunteers and the nurses, even though they were few and far between, they took on flu-related jobs, such as making gauze, face masks, sewing hospital gowns, pajamas. The American federal officials were very busy with the war to focus on the home front, but the Public Health Service had appointed a flu director in each state to disseminate information about the virus and how to prevent its spread. Government leadership varied on a state-by-state basis. Some crowded cities, San Francisco, St. Louis, Milwaukee, Kansas City, all adopted faster social distancing practices and saw fewer mortalities. Many people disagreed with their local leadership use of social distancing, arguing that the restrictions were much too harsh. And that's what we're actually seeing today, again. So things are very similar to COVID-19. All right, next slide, Janet. We're going to now talk about SARS, which actually occurred in 2003. So next slide, Janet. So in late February 2003, I'm going to actually read this. SARS got on a plane in Hong Kong and went to Toronto. Its arrival in Canada was unheralded, but then within days, it began to make itself felt. It killed the 78-year-old grandmother who had carried it into the country, killed her grown son a week later, and spread through the hospital where the son had received treatment. Rather, it quickly infected several hundred other Toronto residents. So this was actually a 64-year-old physician with flu-like symptoms had worked to contain an outbreak of a mysterious ailment in Foshan, China, 2020. That was the physician who got on the plane. Okay, next slide, Janet. And so what is SARS? It's also known as severe acute respiratory syndrome, or SARS-CoV. It's a serious viral infection caused by a coronavirus that emerged in China in late 2002 and arrived in Canada 2003. It was considered a biological disaster. Similar to COVID-19, the virus is presumed to be a zoonotic disease, meaning that the animals are the reservoirs, with origins in China's wet markets. The cases in Canada were down to 0 by June 2003 and worldwide by 2004. All in all, there were about 8,000 suspected cases and 774 deaths from SARS 2003. Next slide, Janet. The signs and symptoms and spread are very similar to what we see today. Respiratory issues, dry cough, hypoxia, shortness of breath, fever, body aches, headache, chills. How is it spread? Much the same way everything else has been spread. Respiratory droplets, cough, sneezes, touching contaminated surfaces like doorknobs, countertops, saliva, skin-to-skin contact like handshakes. Next slide, Janet. Though this virus spans 6 continents, Canada was considered the epicenter outside of Asia. The city of Toronto was hardest hit, and unsurprisingly, patients, those taking care of them, and those visiting them were the ones that were primarily affected by the virus. There were 375 people affected, resulting in 44 deaths. We know that much. Next slide, Janet. So SARS impact had a huge environmental, infectious disease, morbidity, mortality, and population displacement. The SARS outbreak, actually there was the second wave, which was primarily nosocomial and isolated to healthcare facilities. What happened is the nurses who were taking care of those patients did not have the appropriate attire, PPE, to care for their patients. The administration in these hospitals did not listen to the nurses, and that's where we got that second wave, and that's why it's considered nosocomial, because it was spread from patients to nurses and to the visitors that visited these patients. This was an infectious disease, so fears ran very high in Canada, and mostly the attention was given to the city of Toronto. Morbidity, mortality, the rate was like 96%, with high-risk patients being those over 65 with comorbidities like diabetes, hepatitis, much like we're seeing today. Population, people were instructed to self-quarantine if they had been in contact with someone who had SARS. Again, just like we are seeing today. Next slide, Janet. So, communication. Initially, providers were unaware of the SARS outbreak in China. Infection guidelines, control guidelines were constantly changing daily and not always communicated to the frontline staff. Measures intended to stop the spread were relaxed too early, which gave rise to SARS-2. The concerns of the staff were dismissed repeatedly, and that's why they say it was actually a nosocomial transmission. Next slide, Janet. So there were many positive drivers of this disaster response. The positive drivers were the dedication of frontline workers. They were the ones that went to work every day. And many of the excerpts from SARS, from interviews of frontline workers, they felt so committed to their co-workers that they wouldn't abandon them. They would not abandon their patients. When they went home, they knew that they were primarily isolating themselves. They spent short periods of time at home, probably about 2 hours, so they were not as connected at the time to their family, and they were wanted to be very careful not to spread it to their family. They spent greater hours working with their coworkers, and hence that's why they felt that reason to go to work each and every day to take care of their patients and to be with their frontline co-workers. The negative drivers, there were lots. Lack of preparedness, which actually impaired the response. The staff was not safety was not prioritized when it comes to staff protection and infection control measures. The administrators didn't listen to the nurses about the need for more supplies, masks, gowns, gloves. Poor communication and pre-existing weaknesses in the public health system and nurse staffing contributed to the negative drivers. Next slide. So we looked at professional responsibilities and obligations. So there was an ethical dilemma that nurses faced. Do I go to work or do I stay with my family? And what about my professional responsibility to my patients? There was little information about the lethality of SARS in the first wave. There was, again, like I said, the personal obligation to their colleagues. Extended shifts, increased workload related to the staffing shortage prior to the outbreak. So there were lots of issues even prior. And this is one of the excerpts from our book that we used in disaster nursing. At the beginning of the outbreak, I thought I didn't want to be a nurse anymore. Then I thought, what the hell am I thinking? Never once in nursing have I turned away from danger. So this is one of the emergency department and ICU nurse during SARS-CoV 2003. This is one of her responses. Next slide, Janet. The evidence discloses no scapegoats. This was a system failure. The lack of preparation against infectious disease, the decline of public health, and the failure of systems that should protect nurses, paramedics, and others from infection at work, all these declines and failures went on through 3 successive governments of different political stripes. So too, in a sense, we as citizens failed ourselves because we did not insist that these governments protect us better. And this came from SARS 2003, one of the responses. Next slide. The slide after that, Janet, let's go to that one. Oh no, we'll do the other slide first. All right, so we talk about disasters, and so we say, I found this and I like this, disasters are like snowflakes, no two are alike. And so we see many of the same recurring issues. We saw it in yellow fever, we saw it in 1918 flu pandemic, we saw it in SARS 2003, and we are still seeing some of these same recurring issues in SARS-CoV-19. The outbreaks. that have happened. The quarantine, the questions arise about the need for quarantine, the financial collapses, and the financial impact to our society, even today as we speak. What are the long-term consequences? We heard it in 1918, how the nurses were helping patients to adjust to their new normal. And we hear it today, the new normal. But what is it? What does it look like? What will it look like for us here at NYU? We talk about immunity, herd immunity, vaccines. They didn't have any in 1918, and presently we don't have any here with COVID-19. Disaster risk reduction. Were we prepared? What was in place? And when I actually went to the Center for Disaster Preparedness in Anniston, Alabama, I really felt that as a nation, we were the best prepared. I felt so confident that we were so prepared, and that we had this national stockpile for supplies. And you really begin to wonder, were we as prepared as we thought? What about our supplies? What about staffing? And there are many organizational challenges to this that will probably continue to grow throughout. Next slide, Janet. I like this last slide because I found it online, and I think it's something that we should think about as we honor the nurses who are working. So while you are thinking these days about the people who are fighting the battles of their country, do not forget to honor the nurses. They are fighting against heavy odds everywhere and here at home. The sudden appearance of an epidemic has added to the burden of these faithful women and made their task not only more difficult, but more dangerous. There is no quarantine for them. On the contrary, they must be exposed night and day to the disease in its worst form, and the result is that many of them go down before it. There have been many deaths among the nurses in the campus already, and there will be many more before this thing is over. Let everybody do honor the faithfulness and devotion of these women. And let those women at home who have had the training or experience which will enable them to do so hearken to the call of the Red Cross and offer themselves for part-time work at home, so that the registered nurses may be released for active service. And this was actually during the pandemic of 1918. So I just like to end with that slide, honoring the nurses that are out there right now taking care of COVID-19 patients. Thanks, Janet.
Thank you, Theresa. That was really great and very eye-opening. Just the contrast of what's happening today and what's already happened in the past. So many similarities. So I appreciate all of your comments about this topic. Now we want to open it up for questions. So if you have any questions for Theresa, please go ahead and type it into the Q&A box. We've got a few minutes left before we end. If anybody wants to ask any questions.
I wanted to just say one thing before we end. So most of this, I just wanted to give credit to the nurses who my students who were actually in disaster nursing. They were the ones who actually helped prepare this slide presentation from 2 semesters ago. So I've been teaching this disaster nursing for the past 2 semesters. So that's how I was able to put this together using some of their work, which they did incredible work. So I wanted to give them credit. I do not want to take full and complete credit for all of their work, because they did a wonderful, wonderful job the past 2 semesters. And I hope that some of them are online and at this presentation because I want them to know that I'm giving them the credit and great work that they have done.
Thank you. We have a question here. Which drugs are used to treat SARS? Can both remdesivir and favipiravir, I probably just butchered those names, be used for both SARS and COVID-19? I feel that both viruses are evil and similar.
That is something that I really don't know. I know we're using them to treat COVID-19, the remdesivir. I don't know the other drug. So since the viruses are very similar, I don't really know. That you have me stumped. I can honestly say I don't know that one.
Here's another question. One of the major concerns for many schools still remains, how do we reopen in the fall safely? Can you comment on how NYU Nursing is planning to address a disaster on the academic level in the fall for clinicals in the SEM?
Okay, so we don't have a whole lot of information just yet. We know that we are going to be going back in the fall, in September, in a limited capacity. There will be an online component. There may be some in-class participation, small seminars, small groups. As you know, we usually bring in approximately 330 students in the fall semester. And we are not sure how our new norm will look like, but we know it will not look like what we're used to at this time until we're sure that we can keep everyone safe. As far as the sim lab, they are planning to open again. Everything is, all the details are being worked out as far as you know, how to keep the plate, how to keep it clean, how to maintain social distancing, small groups. How often will we work? How long will we work? These are all details that are being worked out by the dean and the task force that she has assembled.
Great, thank you.
Thank you.
Another question, is there anything we can do to lobby with our elected officials to be more prepared for future disasters?
I'm sure that is probably one of the biggest things that we should be doing, is lobbying for our supplies and making sure that we have everything that we need. And I think that this last COVID-19 has really taught us a huge lesson, if not anything at all, but just to be prepared. So I think we are at this point, but you know, we don't know. And hopefully we have plenty of ventilators and gloves and masks and gowns at this point in time. And apparently they're stockpiling millions of these. So that's all I can actually say.
Thanks. Then we've got time for one more question here. It's a long one, so it'll take me a second to read it. We have seen many of the same issues arise again with the lack of PPE, staffing, etc. Many RNs and unions have been fighting for these things with a limited response. In my opinion, there doesn't seem to be much of a plan for how to prepare for a second wave. What do you recommend nursing activists can do to ensure that we do not fall into the same failures yet again? It is clear that history repeats itself, but how can we ensure that the second wave isn't more catastrophic than the first, like the Spanish flu?
That's just it. We don't really know what's going to happen. We really don't. Are we going to have a second wave? We don't really know. I think that that's a difficult question, but I think that because we are now so prepared that we will be prepared for a second wave, we will have all of the guidelines, and hopefully the medications will have medications. I don't know. But I do think that we will have the necessary supplies if and when there is a second wave. I can't guarantee that, but I'm hoping to be positive.
Great. I'm going to keep going a little bit longer because we've got
Okay.
a few really
I
good
don't know that I know all the answers to this.
Yeah, as long as you're okay going a couple more minutes. So we've got some really great questions here. Wondering, seeing the history is repeating itself a few times with the influenza epidemic, it's also true that we as a nation aren't as prepared. So my question is, how are nurses and nursing students taught to prepare themselves in such situations so they can protect themselves, so they can help protect others?
So again, it's the same, the same technique, wearing your mask, gown, gloves when you're taking care of patients. The thing that was most concerning was when the CDC relaxed the guidelines for personal protective equipment, thinking that we could just wear surgical masks. And I didn't agree with it. And I would go out of my way to try and find N95 respirator masks for these nurses, gowns, gloves. We did have that. But yeah, we need to teach them to maintain basic hygiene, wash their hands. You know what you see very predominantly, lots of people are out in the community wearing gloves. Okay, so they're wearing gloves, they touch their phone, they pump their gas, they touch everything. They touch their face. You don't wash your gloves. So the point is, the gloves are essentially useless at this point in time. They're supposed to be worn once and tossed. But you see people walking around in the stores, touching everything with their gloves and never washing their hands, going home. So that's a concern to me, that gloves give a false sense of protection to people out in the community. So I do think that you just need to follow basic guidelines. Wash your hands. You go out, you come back to your home, wash your hands. Use hand sanitizer, the Purell. I think that's most important. And I think that's what we have to teach our nurses.
Great. All right, and our final question, was the second wave of Spanish flu handled any better than the first wave?
It led to the Spanish flu. They actually had a third wave, so which was worse than the first and second waves. So obviously not, because there was a third wave that occurred. So obviously they didn't handle it any better for a third wave to occur. And that's why there were so many people that were killed throughout the Spanish flu.
Wow. So much to consider as we walk through a disaster ourselves for the first time in 100 years. So
Exactly.
it's really, really insightful. Thank you so much, Theresa, for sharing this wonderful historical perspective. Again, I'm just struck by how many things have already happened during this situation. So thank you for sharing all this information with us tonight. And thank you everybody for attending this evening as well. Just want to announce our next event. It'll be on June 17th. We are having an alumni trivia night, just a fun social evening. So I hope that you join us for that. But again, thank you for coming tonight, and stay safe and stay healthy, and enjoy your holiday weekend.
Thank you, Janet. Thank you for asking me to do this.
You're welcome.